So it's my pleasure today to welcome Stephanie Martin. So Stephanie is an assistant professor in nutrition. She received her PhD from Prenatal, and prior to that, she did a master's in adult education from a master's in adult education from George Mason University in Virginia. And prior to going to get her PhD, Stephanie had over 10 years of work doing implementation, design and evaluation of mostly nutrition, but also HIV-related projects in a number of lower middle-income countries. So she brought that experience both to her PhD and to the research that she does subsequently. So Stephanie's research, which is funded from things like USAID, she's also a fellow for the International Society of Human Milk and Lactation Research. Sorry, I'm very possessive this morning. And her research is really fantastic in terms of behavioral interventions aimed at mothers and also broader families to improve child nutrition, looking at implementation science for how we do and perform better evaluations, and then implementation of projects, as well as using qualitative and quantitative, so mixed methods in her research. So we'll get the flavor of that today. Thanks.
Thanks, Amanda, for that introduction, and thank you all for being here today. I'm excited to share a little bit of my research with you and hopefully connect with some of you afterward around shared interests. So today I'll be talking about engaging family members to support maternal and child nutrition. And this has been a large focus of my research, and it's because fathers and grandmothers and other family members are really influential when it comes to maternal and child nutrition. And when you ask women, they consistently list their family members as key influencers of their own dietary practices as well as how they feed their children. And so that's widely recognized now, but we're still a lot of questions about how do we design interventions to best engage them. And more and more we're seeing programs in low and middle income countries trying to do that, but there isn't a lot of evidence about the best ways. And so that's something that I'm looking at in my research. So today I'll provide a very short overview of my current research program and interests, and then I'll share an example with a research project that I was involved in. My role was to try to design a behavioral intervention to increase family support for prenatal micronutrient supplementation. And so that's, if you think about here in the United States, we talk a lot about prenatal vitamins, even though they're both vitamins and minerals that women take during pregnancy. And so I'll talk about that within Kenya and Ethiopia. And it was a multi-phase project that started with formative research and then included a cluster randomized trial and then another qualitative process evaluation at the end. So as Amanda said, I conduct implementation research. I'm currently working on a project that's funded by USAID in Zambia with others here at UNC to evaluate the Scaling Up Nutrition program that's been implemented there, to see how that's going. And then I'm also looking at experiences of healthcare providers and the challenges they face in providing lactation support to families in Appalachia. And then, but the bulk of my work is really around designing, implementing, and evaluating behavioral interventions. So currently I'm working on studies in Nigeria, Tanzania, and Zambia on engaging fathers and other family members for infant feeding, so breastfeeding and complementary feeding. And then in Tanzania, looking at strategies to support women who work in the informal sector so that they're able to exclusively breastfeed. And then finally, with other colleagues in the nutrition department, we're looking at potential strategies to address the dual burden among adolescent girls in an informal settlement in Kenya. And so the behavioral interventions that I'm most interested in are those that seek to improve and increase social support for women, because we ask them to do a lot when it comes to feeding and caring for their children. And so how do we ensure that they have the support that they need to be able to do that? And there isn't really an agreed upon definition of social support in the literature, but I'll share the one that I have sort of cobbled together using lots of other people's definitions. And it's the perceived or received resources and interactions with others that may influence a person's ability to cope with a problem or practice a behavior. And so I'm really interested in the function of social support compared to other measures that look at more sort of structural social network type of issues around social support. And there's people then sort of subcategorize social support, and the three that are most relevant to my work are emotional support, so things like people showing and expressing love or caring and understanding, instrumental support, so the kind of tangible things like someone giving you money in an emergency situation, or informational support like advice or suggestions. And so now I'll shift to this project that I'm going to talk about today, which was, the larger project was really focused on implementing new World Health Organization guidelines around prenatal micronutrient supplementation. And then we were interested in how we could try to increase adherence to those supplements. And this took place in Kenya and Ethiopia. Excuse me. So here's a map of maternal mortality, and the darker the shades, the higher the maternal mortality ratio. So you can see that it's women in sub-Saharan Africa are disproportionately affected by maternal mortality, where rates are quite high compared to the rest of the world. And the leading causes after hemorrhage are hypertensive disorders in pregnancy, and preeclampsia and eclampsia are the conditions that are most contributing to the deaths caused by hypertension. And so there have been several RCTs and meta-analyses looking at providing women with calcium supplementation during pregnancy to see if that can reduce the risk of preeclampsia, and they have found consistently that it can reduce the risk by more than half. And so it's a pretty efficacious intervention. And based on those findings, WHO has released a series of recommendations around calcium supplementation in pregnancy. So these first came out in 2011 when they were creating guidelines around a package of interventions to prevent and treat preeclampsia and eclampsia. Then they released guidelines again in 2013 that were specific to providing calcium supplements in pregnancy. It was reaffirmed in 2016 as part of new recommendations about improving antenatal care for women in pregnancy sort of more broadly. And then just last year, they did another meta-analysis to see if there had been new randomized control trials completed in additional settings to see, is the evidence still there to recommend calcium supplementation in pregnancy. And so as part of this recommendation, it's suggested that they integrate calcium supplementation into ongoing antenatal care services. And as part of that, iron-folic acid supplementation and iron supplementation has been recommended for decades because iron supplementation in pregnancy can reduce the risk of maternal anemia, and it can also reduce the risk of low birth weight in babies. And so that's something that's been recommended for a long time. But just to give you a sense of what these recommendations actually look like in practice, so WHO recommends that pregnant women take 3 calcium supplements, so those are the 3 white pills, and 1 iron-folic acid supplement, which is the pink pill, every day. And because our bodies can only absorb so much calcium at a time, you have to take them at separate times throughout the day. So you would take calcium sort of morning, noon, and night, and then a little bit later in the evening, you would take your iron-folic acid supplement. So when these guidelines came out, I remember hearing them and just thinking that they had sort of lost their mind over at WHO, because we know from decades of implementing iron-folic acid supplementation programs that those are not working well. There's problems at every single level. So there's problems with supply, there's problems with distribution and how they're dispensed to women when they come to antenatal care. It's very common for there to be stockouts. And then at the individual level, women also have many barriers. So just taking the one iron-folic acid pill. And so really, in order to integrate calcium into antenatal care, would require substantial health system strengthening efforts as well as effective behavioral interventions. And so that's what led to this study that was really looking at, are these WHO guidelines acceptable to women and to healthcare providers, and are they feasible? And so we looked at this in Western Kenya in Kakamega County, sort of above Lake Victoria there, and then in Oromia region in Ethiopia. And we, as I mentioned, it was there were multiple phases. So we did a first round of formative research, And then a second round of formative research where we used qualitative behavioral trials that I'll talk about. And then that led to a cluster randomized trial and a process evaluation. So today I'm really going to be focusing on the efforts to engage family members to support calcium adherence and iron-folic acid adherence. But there was a ton of work just around sort of the acceptability of these recommendations in general. So if people have questions about how that all turned out, I'm happy to talk with you afterwards. But I'm more interested in what the families and women's experiences were. So as I mentioned before, my role was to design a behavioral intervention to try to support adherence for this really complicated regimen. And so the first round of formative research we did was pretty typical of formative research. We interviewed pregnant and postpartum women and nurses and community health workers and traditional birth attendants in both Ethiopia and Kenya, about 40 participants in each country. And I won't spend a lot of time on those methods, but we found similar things that were well documented in literature. So there were challenges around supplies and stockouts, counseling. Women frequently reported that they didn't know why they were taking the pills that they were given, and that forgetting was also a barrier to adherence. And then in all of that sort of bad news, I guess, there were some opportunities that we thought that we could build upon, and one of them was around family support. There were a few women, not many, but those who reported being able to adhere to their iron-folic acid supplements talked about being reminded by someone in their household. And so there was a woman in Kenya who said, "I cannot forget. That is the first thing grandmother would ask me. If I've forgotten, she will tell me to go and take them." And so this idea of having somebody at your home remind you to take pills is something that's not new. It's something that's been used for other types of interventions. It's been tried several times with HIV treatment with varying degrees of success. But it seemed like it was a potential strategy that we could use for this. And so the idea would be is that women would ask someone to remind and encourage them to take their pills. And what I like about it is that it expands existing supportive relationships. So you would only ask someone who's already helping you with something anyway. If you have a relationship with a partner or other people in your family who aren't supportive, that's not who you're going to ask to then be the person to remind you to take these supplements. And at the time that we were doing this, I had just finished another intervention in Western Kenya to try to engage fathers and grandmothers in infant feeding. And we had sort of peer education support groups that were led by fathers and grandmothers. And they were wonderful. And they spent a lot of time sort of examining their roles in the family and gender norms. And it was great, but it was really cost and human resource intensive to run those programs. And so I was really interested in looking at, is there something really small that we could do that could help support women and increase family support and wouldn't require the kinds of resources that intervention did. And so that was sort of what led us to this adherence partner idea. And adherence partner is the word that we use to describe this intervention sort of in our study team, but it was not the term that we used to talk about it in either setting. And so to test the idea of an adherence partner, and while we were also sort of testing these WHO recommended prenatal micronutrient supplement regimens, we used a formative research approach called Trials of Improved Practices. And what I like about it is it gives you a chance to pre-test actual practices that a program is going to recommend, and you can hear from participants as they're trying them. And so you conduct a series of home visits, and during that time, participants are trying the recommendations. And so you can document their experiences with them and then also identify facilitators and barriers. So how it typically works is at the first visit, you ask someone, are you willing to try this practice? And they tell you yes or no, and they tell you why. So you get a sense of like, just right off the bat, how realistic does this seem to people? And then you come back a couple weeks later and you see, did they actually try it? What were barriers? What were facilitators? And then you go back again a couple weeks later to see, how is this going? Did they make any changes to the recommendations? Were there any modifications? Do they plan to continue doing this? And so in doing that, you get a sense of how realistic are these recommendations that you're promoting. And so we did that in Kenya and in Ethiopia. We proposedly sampled pregnant women. They were recruited from health facilities and through community health workers. In Kenya, we started out with 35 women, but we learned that women who are pregnant give birth, and sometimes they do that before you're ready for them to. And so in Ethiopia, we oversampled, but we also tried to get women earlier in pregnancy, and in doing so, we had more women finish. But that's why there's the discrepancy in the numbers. You'll see that numbers kind of sort of go down with every visit. But we conducted in-depth interviews with each participant. So one interview every 2 weeks for 4 to 6 weeks, and there were 3 to 4 interviews with each one. And at the first interview, women received the supplements and extensive counseling about how to take the iron, folic acid, and calcium pills. And then they were offered, if they would like to have, ask someone to help support them to take those pills. And we also measured general social support because we wanted to get a sense of what their home environment was like. And so for each of those interviews, we analyzed the transcripts thematically, working with a team of 3 qualitative researchers and using Atlas TI. And then we also tally participants' choices. So we summarize them using basic math, but it's not meant to look at sort of relationships, but just for our own understanding of how it's working. And so the mean age was similar in both settings, around 25. And then in Kenya, there were fewer women who were pregnant for the first time, and about double the amount in Ethiopia. The education levels were very different between both settings. In Kenya, most women had completed primary education, but in Ethiopia, more than 80% had not. And then antenatal care use was much higher in Ethiopia than in Kenya among our participants. But then in both countries, most women were living together or married to their partner. And so the first visit, we found that most women were willing to ask someone to be their adherence partner. And this quote from a woman who was pregnant for the first time in Ethiopia, she said, "I'll ask my husband because this is our common concern. My health problem will affect him. This baby belongs to both of us. I think he will remind me for the sake of the baby in the womb." And so most women felt like this was a reasonable thing to ask someone to do, and they planned to do it. So when we came back 2 weeks later, again, most women had indeed had an adherence partner. A woman who was pregnant for the first time in Kenya said, and some people would pick more than one person in their family to be their adherence partner. So she asked many people in her family to help her remember to take her supplements. And she said, "Many people helped me, many encouraged me. I was happy that many were on my side. They were also happy to encourage me to continue." However, there were women at the second visit who hadn't had an adherence partner, and so we were interested in looking at why. And using scores from the social support scale that we had used, we found that there were most of the women, or some of the women talked about not having anyone to ask to remind them. A woman who had been pregnant before said, "It's difficult. Who will sit with you and talk about this? There's no need for an adherence partner." And the other theme that came out of our analysis was that women appeared to be more self-reliant. And so they would say things like, "I'm taking the pill by myself. The advantage is for me and my baby. Why would I ask others for help? I don't need to ask anyone." And so it was sort of like, this is such a basic thing for me to do. I don't need to ask anybody to help me. I can do this on my own. And so for them, it wasn't something that they were interested in, which is fine. And so what we did was we categorized women based on their levels of social support and self-reliance. So women with higher levels of social support are on the top, with less support on the bottom, less self-reliance on the left-hand side, and more self-reliant on the right. And you see that the black color is women who chose an adherence partner, and the gray is women who didn't. And so most women chose an adherence partner, but those who didn't really fell more on the more self-reliant side. So it wasn't something that they were necessarily interested in working and having. And so, but the combination of self-reliance and low social support sort of makes you wonder, are they more self-reliant because they have less social support? But it wasn't something we had thought about before going into it, so we don't have tons of information about that relationship. And then we went back for the third and fourth visits to see, did women continue to have adherence partners? And again, most women did continue to have someone remind them. A woman in Kenya said, I want my husband to continue. He reminds me if I've forgotten. He brings them to me, and when he sees I've given up, he encourages me to continue. You know, if someone loves and cares, he will help remind you about something concerning your life. And so, so we felt like for most women, it was something that was a positive thing that they wanted to continue, but there were people who said their husbands or other family members had stopped sort of serving in that role as time went on. Either they had stopped reminding them, or they were out of town a lot, or the women felt like they no longer needed help, so they sort of moved into that more self-reliant category. A woman in Ethiopia said, I asked my husband, mostly he reminded me to take my pills, but the problem was that he works early in the morning and comes home in the evening, so it's difficult to always get him due to the nature of his job. And so having someone who's around and available consistently is important for this to work. And so based on this analysis, we felt like, in general, adherence partners were very acceptable to most women in the two countries, in the two settings, but that alternative adherence strategies would be needed for women with more self-reliance or less social support. And so this isn't, the idea isn't that this would be an intervention that would help everyone, but it could be something that would be helpful to some women. And it seemed like a potential low-cost strategy that warranted additional study in the trial that we were planning. And so this strategy is designed to increase social support, so I just want to spend a second talking about the differences between general social support and specific social support. And so general social support is what contributes to sort of overall well-being, and sometimes you see social support is positively associated with various health outcomes, but the relationship isn't consistent in the literature. Sometimes there is no relationship, sometimes it's negative. And so that's something that I became very interested in and started thinking more about specific social support. And so in the case of prenatal micronutrient supplements, that would be like getting reminders or being encouraged or having someone who helps you overcome barriers to adherence. And if you think about it, if you have a family that's super supportive, so you have lots and lots of general social support, but they think that taking prenatal micronutrient supplements is going to harm the mother and harm the pregnancy, the chance of that high level of support translating into adherence to prenatal micronutrient supplements is very low. And so I think it's really important to focus on social support that's actually related to the behavior that we're interested in promoting. And so I wanted to make sure that we were measuring this accurately. There weren't examples of adherence-specific social support scales in general, and certainly not any that had been used in East Africa. And so we used cognitive interviewing to try to assess the appropriateness, acceptability, and comprehension of general and specific social support scale items. And so cognitive interviewing is a process sort of before pre-testing survey questions where you use think aloud probes, ask people to paraphrase the questions that you just read, and then have other sort of hypothetical probes about how do you think other people in your community would respond to these questions or understand these questions. And so we used 2 rounds of cognitive interviews with 24 women in both countries. And the reason we used 2 rounds is because the first round failed miserably. And so I'm going to talk a little bit about that because it was a really good learning experience for me. And so how often do you get to talk with someone you trust about your personal and family problems? That's one of the items from a general social support scale that's been used in several countries in sub-Saharan Africa. And so we thought it would be a good one to use for our study. And so after we asked that item, we would say to participants, please tell me what you were thinking as you answered this question. Can you explain to me what this question is asking in your own words? So asking people to paraphrase it. Are there words or phrases that are confusing or difficult to understand? So we have a series of questions about each item. And there were 10 items on the scale. And then in addition, we also asked them questions about the response options. So the response options for that existing scale were much less than I would like, less than I would like, and as much as I would like. And then we'd ask them, why did you choose that answer? Was it difficult? What do you see as the difference between much less than I would like versus less than I would like? And so these were questions that I thought were really going to be interesting. The participants did not enjoy them at all. And so there were challenges both with the social support items themselves. So we asked a question about how much love you feel from your family member. And Woman in Ethiopia is one of my favorite quotes. Love can only be expressed by words. It cannot be measured. When you asked me this question, I was confused. I don't have a machine to measure love. Your questions are very simple. So while this is happening, my colleagues from Ethiopia were calling and like saying, we need to stop doing this. It's horrible. And I didn't really get what they were saying until I started to see the interview transcripts. And I agreed. And so another one, when we asked them about sort of the difference between much less, a little less and much less, someone in Kenya said there isn't a big difference between less and much less. The difference is small, there's no difference. And so thinking about what response options we use are really important. But then what was really sort of hard for me to hear was the challenges with the cognitive interviewing process itself. And so all of my sort of work in this field is driven by a desire to sort of increase support for women, help women to, have the best lives that they can have. And through this process, we were actually making women feel worse when they were talking to us. And so when we would ask women questions, they would say, I don't know, or I wasn't thinking, and which doesn't sound that bad until I show you the next quote. And then, so despite initially being willing to talk with us, very early on, they would start to appear very frustrated and asking us to stop. And so there was a woman in Ethiopia who said, I don't understand, I don't know how to answer, I am illiterate, I can't answer what you're asking me, let me go, please. And that was like, okay, we're gonna stop what we're doing. And this was with very few women, but it really, I would never want someone to be in a situation where they're feeling worse about themselves and thinking about their own sort of lack of education as a reason why they're not able to answer a question. And so we immediately stopped what we were doing, and we completely revised the process, and it ended up working much, much better. But it was a really, like this approach had been suggested to me, and I was really excited to use it because I really wanted to make sure we were capturing what the support that people wanted, and we were going to have this really accurate measure. And so that led us to revise what we were doing. So we eliminated all of the think out loud questions, all of the paraphrasing questions, all the hypothetical probes. And instead of asking a probe after each item on the scale, we asked targeted probes after they had completed the whole scale. And so also we changed the response options from how often to do you, so allowing a yes or no response, because that was much easier for participants. Even when data collectors would have like a bigger pile of rocks next to a smaller pile of rocks, just try to show more and or less and a little bit less, it still was something that was challenging. And so we ended up getting a lot of feedback from the interviewers before we tried the second round of cognitive interviewing, and then we finalized the scale based on participant feedback as well as interviewer feedback. But just, I don't know, I think it's an important thing to share because a friend of mine did a similar cognitive interviewing in Bangladesh, and when this happened, I was like, this isn't working well at all. And she's like, oh yeah, it's really like hard to do and really kind of frustrating. Like, why did you? I don't know. So there's a whole literature around cognitive interviewing and trying to use cognitive interviewing in cross-cultural settings, and it really is very different depending on sort of the education systems that people are used to. And if you're used to sort of, being encouraged to question a person in authority who's asking you a question, it's very different than a setting where it's more sort of didactic. And why would a woman with low education in Ethiopia think that she should question or give suggestions on how to improve a scale item from someone who's driving to her village from a university there? And so it I'm glad that it was only a few people that went through that process, and I think I picked the quotes that make it seem as extreme as possible, but it's a good thing to keep in mind, and sort of has changed the way that we go about designing survey questions. And so based on all of that, we're starting a cluster randomized trial to look at the ability and feasibility of this prenatal micronutrient supplementation regimen. And so I was able to look at the questions that I was interested in, which were, can adherence partners be included in routine antenatal care? Are healthcare workers going to suggest adherence partners? We know healthcare workers are really, really busy. Are they going to add one more thing in while they're being asked to describe this super complicated calcium regimen? And then will women choose to have an adherence partner when it's not something that's promoted to them through counseling that's done at their house? Do adherence partners enhance adherence-specific social support? And is adherence-specific social support associated with adherence? And so this was all done within a larger trial that was integrating calcium supplements. And so as part of that, healthcare providers and community health workers were trained on the calcium and iron-folic acid supplementation. We provided facilities with the supplements because we knew that supplements, having a consistent supply of supplements is a barrier. And so we wanted to eliminate that right off the bat because otherwise we wouldn't really be able to look at it because calcium wasn't even really available for government health facilities in Kenya at the time. And we also provided counseling cards and calendars for women to take home. And then, but it was while we provided those supplies, all the services were still provided by the healthcare workers and facilities. So it was their routine antenatal care. And then for the adherence partner piece, we trained all health workers on the adherence partner strategy. And we included a counseling card with information about adherence partners as well as a calendar page. And then we provided posters for, to health facilities to give to women that they could take home and share with their partners. So this is the translation of the poster that we provided. So this trial was done in 16 antenatal care clinics in Malaba sub-county and Kakamega County in Western Kenya. We had 914 women come back for the 4 to 6 week follow-up. Immediately after their first antenatal care visit, they participated in an exit interview where we were asked about the counseling they received and whether or not they got their supplies, their supplements, and then they came back. They were invited to come back 4 to 6 weeks later for follow-up where we measured social support and adherence using pill counts as well as self-reports. So among the participants in the trial, the mean age was 25 years. Almost all of them were Luhya ethnicity, which is the main ethnic group in that part of Kenya. About 3/4 had completed primary school or higher. Almost all were married, and about 1/4 were pregnant for the first time. So going back to my questions, was the adherence partner strategy included in routine antenatal care? So at the exit interview, the majority of women were counseled about having an adherence partner. More than 90% had received a poster to take home to someone in their family, and 84% intended to ask someone. So then when we followed up with them, 4 to 6 weeks later, we saw that 90% of women chose to have an adherence partner. Most of them picked their spouse, but the next category was elder women, so either their mother, mother-in-law, grandmother, aunt, and then a fair number of people had their children serve as their adherence partners. That wasn't something we saw in Kenya in the trials of improved practices, but it was something we saw in Ethiopia, and so it was interesting to see that it was a sizable number, and then the rest were either pure-aged female relatives or friends, and then male relatives, not spouse. And so are adherence partners associated with high adherence support? More participants with adherence partners reported high adherence-specific social support than compared to those without adherence partners. So the challenge with this analysis is that we did not randomly assign adherence partners to facilities. So everybody was offered the adherence partner intervention. And then we confirmed this relationship with mixed effects or logistic regression. And then we asked them, are you satisfied with having an adherence partner? Do you plan to continue? And overwhelmingly, women said they were satisfied and planned to continue. So then the big question, is adherence support associated with high adherence? And using a mixed effects logistic model, we saw that with calcium, high adherence specific social support was significantly associated with high adherence, but we didn't see that same relationship with iron and folic acid supplementation. I have ideas as to why. I'm happy to talk about. But then feeling worse was also significantly negatively associated with adherence. And it's interesting because a lot of the literature around prenatal micronutrient supplementation says that we make too big of a deal out of side effects because really these problems are these larger health system problems. But in this case, we sort of removed all of the health system problems. And when you remove the health system problems, side effects continue to be a barrier. And so I thought that was interesting. So just to sort of summarize what we found from this, antenatal care providers promoted adherence during routine antenatal care, and women chose to have adherence partners. Those adherence partners were, having an adherence partner was associated with higher adherence support, and high adherence support was associated with high adherence to calcium, but not to iron and folic acid supplementation. And so then we also did a process evaluation to see sort of what had happened, because up until now we've heard a lot about women's experiences having adherence partners, but we haven't heard from healthcare providers about what it was like promoting both this new regimen of calcium supplementation, but also promoting adherence partners, and then from the adherence partners themselves. And so we proposedly sampled antenatal care providers, pregnant women, and the pregnant women were chosen based on their adherence levels as well as whether or not they had chosen to have an adherence partner. And then we had 20 adherence partners, mostly husbands, but some mother-in-laws, mothers, and grandmother also participated. And so again, we did in-depth interviews with these participants, and all of the interviews were translated and transcribed, and we analyzed them thematically using the constant comparative method, using, again, a team of, in this case, we have 5 people on our team analyzing these transcripts, and used ATLAS-TI. So for healthcare providers' experiences, all of the healthcare providers were in favor of the adherence partner strategy. One nurse said, it's good when you have somebody who's encouraging you to take it, at least you feel you have somebody who's caring for you and who is concerned. And then, even though we heard a lot from the women, we wanted to hear from them again and how it's different getting these through antenatal care versus at home. Almost all women with adherence partners reported appreciating the support. A few reported that their adherence partners stopped providing support, similar to what we saw in trials of different practices. And then one reported that the reminders from her husband were excessive. Sometimes we're not feeling well or tired, and maybe somebody is persisting, you don't feel good, at times you tell them to get off your case and he persists. If somebody keeps persisting, I don't like it. And so this has been my concern for years about engaging male partners in maternal and child nutrition. I think it's a domain that's traditionally a place where women have control and autonomy and are able to make decisions about their own health and their child's health. And so I'm always sort of wondering, is encouraging more male support going to actually reduce the control that women have over that area of their lives? This is the only quote I've seen in the work that I've done here, and another study in Kenya and another study in Tanzania that really talks about this. Overwhelmingly, you hear women appreciating the support. Granted, we're only working with women who have someone who they want to invite into this study with them, so it's a very biased sample in terms of that, but it's always something I'm sort of on the lookout for. And there's an example from a study in Peru on iron and folic acid supplementation where they talked about the husband grabbing his wife's arm and reminding her to take her iron and folic acid. So, I mean, I think it's something, when thinking about engaging other people who aren't typically involved in these areas, is something to sort of keep in mind and be on the lookout for. But it's, in my experience, has really been the exception and not the rule. And so in terms of the adherence partners' experiences, they've reported providing instrumental, informational, and emotional support, and the women confirmed this. We looked at adherence partners' transcripts with the women and analyzed them together as a couple, so we could really see if the partner's saying they're doing, you know, X, Y, and Z is the woman saying that she's also receiving the support, and we did see that. The adherence partners seem to be motivated by the benefits they saw to women's health for these supplements, and then providing adherence support seemed to be consistent with the role that they viewed for themselves in their relationship with the pregnant woman. So one mother said, I have to make sure that she eats something and does not stay without any food. I have to try to find something that she can eat, and so she can take her pills after the meal. So the way she sort of talked about it is this is her responsibility as her mother. And then a husband said, when your wife is healthy, you feel proud. If she has a safe delivery and the baby is healthy, it's to your benefit. Also, when you're helping and reminding her to take her medicine, it improves the relationship and brings you closer and builds your marriage together. And so, in summary, I found that it's really important to measure adherence-specific social support when you're looking at social support interventions to make sure that the kind of changes that you're hoping to make are actually happening. And then adherence partners are, I think, a simple, low-cost behavioral intervention. They, in this study, they were associated with increased adherence support, but it really isn't appropriate for all women, and it's also not appropriate for all interventions. So compared to other nutrition interventions that I work on, like complementary feeding or breastfeeding, they're much more complicated and multifaceted than supplement adherence. And so I wouldn't recommend, and I wouldn't try using, sending a poster home with a woman about complementary feeding and think that that was going to make changes. This is an intervention where the supplement is provided for free. In both, especially in Kenya, women are so used to not having access to iron and folic acid supplements in this part of the country because they were so, stockouts were so frequent that they were happy to have the pills, they were motivated to take them. It was really just like a little extra support to help with adherence. And so I think other interventions really, especially around engaging fathers and grandmothers where you have cultural norms and roles, really does require a more intense intervention that this example doesn't provide. So with that, I will stop and be happy to take any questions.
So what do you think was the reason for the lower adherence to iron?
So it wasn't that the adherence was lower. The adherence, so I didn't show it.
Oh yeah, you actually,
the adherence to both was about, it was 86% to iron and 88% to calcium supplementation. So the adherence was really high in both groups. But I think the reason, I think that the social support didn't matter for the iron. Like, I think it's an easy enough behavior that it just wasn't, I don't know. That's
because it's once per day?
Because it's once per day. And the other reason why I think it matters that I didn't really go into at all, but I think I have a slide on, maybe? No, did I delete it out? Oh yeah, it's this. So this is what our calcium, this is what our, so I think household hunger also factored in with calcium adherence in a way that it didn't for iron supplementation. And I think that it was, a lot of people, the support they provided was providing food to women. And so I think that for calcium, it really looks like you have to eat this giant breakfast, lunch, and dinner in order to take your calcium supplements, which was a huge mistake on our part. Because the idea is that if your diet isn't adequate, then these pills will help with that, and it would be better to take it with food, but you certainly don't need to have this enormous, like, I don't even know, like 3,000 calories a day of food. And so I think it was just a more complicated regimen that required more, and that the support mattered more for calcium. I don't know, that's sort of my hypothesis, is that there wasn't, like iron and folic acid they've known about for years. I think the real barrier for that has been supply issues. In some, when we looked at I mean, we looked at these data all different ways, and in some, I can't remember now if it was with the self-reported data versus the pill count data, there was a significant relationship between iron. It must have been with the pill count data that there was a significant relationship between social support and iron-folic acid. But when we look at the self-report, it also didn't continue. So,
because I mean, you're basically taking the iron at the same time as the calcium, so in this picture at least. So
right, this is a picture. So we had multiple regimens where some try to take it at the same time because there's sort of debate about whether or not with supplementation, if it really, the calcium would really interfere with iron absorption as much as people are worried about. But so I think it's just because it wasn't as, I mean, that's my theory, is that it wasn't as complicated.
And the 86% adherence, was that to every single day, or did you build in room to not do it?
So it was 86% of the total number of pills
they should have consumed
during
the whole thing.
the time period. So it was really high.
Yeah, it is.
And I mean, I don't know. I thought, oh, adherence is going to be so easy compared to, you know, diet data. This is going to be great. Adherence is not easy at all. So we used in the tips we used we had bottles that had electronic monitors on top, so they would keep track of how many times you opened the supplement bottle. But people would open this; they didn't want to carry this giant thing with them all day, so they would open it, do what they called pocket dosing, and then so that wasn't that sort of held up as this gold standard, but it wasn't.
And did you do any like biomarker measurement to see if you could detect, you know, improvements or at least not downturns?
So unfortunately with calcium you can't. There's no biomarker to see, and we didn't look at iron.
Well, I'm curious about what you think it is in terms of the mechanism of social support that makes this intervention work. For example, like, is it just having the reminder, or is there something in addition about the relational aspect? Like, if you were to do an intervention like this where women receive like a text message 3 times a day, do you think it would have been just as effective?
So I think maybe with supplementation it would be. There were women in the study that said that they set an alarm on their phone and use that to remind themselves. I think in other work that I've done with more sort of complicated behaviors, so with something like exclusive breastfeeding, using empath analysis, we've seen that by increasing social support, it increases women's self-efficacy, which then improves exclusive breastfeeding. And so you see it operating through self-efficacy. I think in this, it would be interesting to compare having a human remind you versus a phone remind you and see what the difference is. Because a lot of it, I think, is just forgetting. But I think the only difference is many women talked about having their adherence partner help them overcome sort of side effects, or if they're like, I just don't want to take this anymore, which is reasonable when you see like taking 4 pills a day. I think so that kind of support you couldn't. I mean, I guess you could have a text message that was like super motivating, like, I know this is horrible, but you're doing it. But yeah, it would be interesting to compare. But certainly for other kinds of interventions, I think having that social support. And I mean, I think from all the work around engaging families that I've done, there's always these just lovely quotes about people's relationships getting better and communication improving, and that we're not necessarily the focus of the intervention. And so I just think for women's lives, it's nice to have that support too.
You showed a picture, I think one of the a picture of pills themselves. How big were they?
They're big. They're like, I mean, calcium. So the iron isn't that big. It's probably, I don't know, not that big. But the calcium is like, I don't know. The one, does anyone, they're like
An inch long.
Maybe, I don't know, like that size. We also tried as part of this giving chewable, like the candy kind of supplements. And so in Ethiopia, we used fruit flavored and chocolate, like the chocolate ones that people take here, and they did not like the chocolate ones at all. Originally, we were supposed to get a drug company was going to donate calcium supplements to us in all different kinds, so we could try out all the different ones, but then it turned out that they weren't approved for the climate in either Ethiopia or Kenya, and so they ended up not donating those, and so we had to buy the regular calcium supplements that were available in the country. And yeah, they liked, I think having calcium supplements that taste better would certainly be something. They were very acceptable in both, not the chocolate ones, but the more fruity ones. And the cost, it's interesting because we were sort of thinking that the cost of the supplements would be like the barrier, but in talking with someone in the food industry, they said that really the calcium is what is expensive, and so it shouldn't make a difference if it's looks like more of a Tums versus something like that we have to swallow.
I just wonder about the swallowing part. If people are not used to doing that, it can be a trick.
Yeah, we did a lot on the organoleptic properties of the pills, and it didn't really seem to be a big. I mean, there were a couple women that sort of talked about like it getting stuck in their throat and choking, because also you need water to take it, and water insecurity and having like clean water that's available specifically for this isn't something we looked at in this too closely, but overall it seemed pretty acceptable. We were surprised. I mean, I thought this whole thing was going to be like, no one's going to take the pills, no one's going to remember to take it 3 times a day, nobody's going to want to do it. But I think I was surprised that that women actually appeared to be taking the pills. I mean, I guess they could have, like, we always joked, like, are they walking back to the health clinic just shaking out the bottles? I mean, it's possible. It's everything.
So basically they preferred the pills to the cognitive interview.
They definitely did. Yeah, those cognitive interviews are so awful. I felt like, yeah, sorry. I think, was there a question back? Yeah.
Go ahead.
Yeah, I was just wondering about spillover effects. You mentioned some already in the qualitative interviews, but I was wondering whether there were like spillover effects in terms of like support to accompany to antenatal care visits, or even reminding of those, and whether you were able to measure something like that.
So we didn't, there were some, in terms of women who were having side effects in the qualitative interviews, they would report that they would be encouraged to go to the health clinic by their partner. So that was one way. I mean, there's lots of barriers to men attending antenatal care in Kenya. I'm more familiar with it in Kenya than I think in Ethiopia, but there wasn't, I can't think of anybody saying that their partner went with them to antenatal care.
I actually had a question about the cognitive interviews. So, because I had a similar experience with that here when I was doing WIC and SNAP interviews. So just like totally different context, but still just like people being frustrated with like why are you asking me? And like, I don't know, all this kind of seems the same. And I'm just like, I'm curious your perspective from like a measurement point of view, because it's like, I struggle with that a lot. Like, well, I don't really think the answer is to not do cognitive interviews. Like, how do we do, like, how do we do those in a way that is, respectful of people, but it's also helping us to improve the instrument? I mean, what's your perspective on that, like, moving forward?
So I still think it's really important.
Yeah.
And so I feel like just those, like, think aloud, I think, is annoying to have to do. I just, like, if I'm the person.
Yeah.
I think what we did the second time where we asked the whole scale and then said,
Right.
what are the, like,
Instead of item by item.
right, because the item by item, it's just too much. And I think for us, sort of asking before we got to the specifics of the scale, like, what is it that you expect in terms of support or whatever the thing is? Think about beforehand, and then see. I mean, the thing that was interesting to me is that when we would talk to women, I'm like, wow, these women have so much support. And when they'd answer the questions, they're like, nah, I don't. And I'm like, but you have so much more support than the woman. But it's really about perception. That's really not. Question. But I think sort of being really really intentional about how you're asking those questions. And there's a huge, I was surprised how big of a literature there is on critiques of cognitive interviewing. Like in field methods, there's a bunch that have been done here in the US with different communities as well as outside of the United States, and sort of what strategies people use.
Because I mean, I'm not that familiar with that literature, but I was also thinking to myself, like, I wish I would have gone back and like done initial cognitive interviews with like WIC clinic people, somebody kind of like in between, do you know what I mean? Like, or some kind of community health worker, that would be able to give me that perspective without feeling like I was like.
Right. No, I think that's a good idea to do initial work up front. And so I felt like we had a lot of qualitative work that sort of went into forming those questions. But I mean, there were these scales that have been used all over the place.
Sure, that's
with response options that are used all the time. And I'm like, no one understands these response options. There's a whole literature around how people don't understand those kinds of response options, and that's what we do. Sorry.
Thank you. Thank you for sharing your work. The two countries you mentioned, the context and the cultural context. You also measure what you measure. But what I was interested to hear from you is, both from the woman's side, the mother's side, and the person providing support, did you have any question which asked the reason they provided? I think you mentioned, but did they explain whether it was mother's health as the primary purpose or it was a child's health primary purpose? Because there's a lot of evidence which says primarily people provide support. They look at the mother, but actually they're looking at the child, which doesn't show up. So did you investigate that part?
Well, so we asked them what motivated them, and in both countries, they talked more about the mother's health than the child's health. And so I don't know if that's just because we were asking during pregnancy, and so the thought of this child that isn't born yet is not sort of top of their mind. But it seemed that was what was sort of motivating it in both countries. And that I have much more experience in Kenya than I do in Ethiopia, but from my understanding and reading ethnographies of that region of Ethiopia, there is sort of an expectation that husbands support their wives during pregnancy and the immediate postpartum period. And so that was very consistent with what was expected. Even like you would, if a husband is not being supportive, you would take him to sort of the community leader and be like, this person is not helping me. So, but I mean, like you, I feel like so often with nutrition programs, we're just using mothers as a vehicle to try to reach children and not focusing on their own health. And so for the most part, I mean, there's things, I mean, sometimes I wonder if it's translation, but like the quote, one of the quotes I showed, it said, it's to my benefit for the mother to be healthy. And it's like, you know, you could read into that a lot of different, like, oh, it'd be really hard if my wife died. I mean, you can just sort of have a cynical view of it, or maybe just the way
Hi. So my question is more about more complicated behaviors like exclusive breastfeeding, complementary feeding, and in the qualitative work, did it come across at all about the power dynamics between grandmothers, fathers, mothers? So I'm thinking that grandmothers typically sort of quote own the space around infant and young child feeding practices, and so if a father is the partner that a mother, sort of the adherence partner that she chooses, how does that dynamic play out? I don't know if it comes out in the supplement kind of work, but
it didn't really come out in the supplement work. I'm trying to think. So the work that we did in Kenya, we had separate grandmother groups and father groups, so it wasn't like, so with the grandmothers around infant feeding, I'm trying to think if it, I know in like a certain context, you really see the mother-in-law like owning that space and controlling it. And I feel like the research that I've been doing in East Africa, women are really talking about their male partners more. I mean, they're still talking about the influence of grandmothers, but I feel like it's not, I don't know, I don't have quantitative evidence of this, but in terms of the qualitative work that we've been doing, it seems like having the husband on board then will also allow for the grandmother to become part of it. I don't know, it didn't, with this, it really didn't come out. I mean, with this, the real barriers were neighbors. And so there was one woman who had someone say to her, like, I can't believe you're taking those calcium supplements. I'm going to see your baby is going to weigh 7 kgs. Like, this is a really awful thing. And so I think those were the bigger problems than within the household. I don't know. I have to look at my more breastfeeding complications stuff. Think about, I think in our work, and so we just finished a study in Tanzania on engaging fathers, and it really came out that we needed to do more to engage mother-in-laws because the message was that, with exclusive breastfeeding, you need to do it a lot. And the family was sort of resistant to how much time the mother was devoting to exclusive breastfeeding. And there were several family members who complained about, you can't just sit around all day and breastfeed, you need to be doing other work. And so I think that wasn't with the father, but it was sort of, because we didn't involve the grandmothers. I think it was a big limitation with that other study. And that's why this is whoever likes.
Were there any noticeable differences between multi-gravida and pre-gravida women with respect to willingness to try the adherence partners?
So I didn't show it, but in the trial, women who were pregnant for the first time had an adherence partner more often than women who had been pregnant before, so which makes sense. Yeah, that's a great question.
I think we have to cut it off, but I'm sure Stephanie will answer more questions if you have them. So give her.